Um, Good morning and welcome to today's Cardiology Grand Rounds, and a particularly warm welcome as well to our fellowship applicants joining us today. It's my pleasure to introduce Dr. Andre Davila and Dr. Timothy Marr to deliver today's Grand Rounds. Dr. Davila is the Director of VT Ablation at BIDMC and is an internationally renowned clinician, educator, and researcher. His team has pioneered the field of epicardial ablation, and Dr. Davila was instrumental in bringing this technique to the US. Dr. Marr is the Associate Director of VT Ablation and co-directs the VT Center at BIDMC along with Dr. Davila. He is a graduate of this cardiology and EP fellowship program, and since graduating fellowship, he and Dr. Davila have developed a world-class program for management of complex VT at BIDMC. They offer techniques that are only available at a few expert centers in the US, and they both lead multiple industry-supported investigator-initiated grants for clinical, preclinical, and translational research. Thank you both for joining us today, and I look forward to learning more about whether we're really moving the needle with VT ablations.
Thank you. So I will basically kind of introduce the subject, and with Tim. Do you have your slides, Tim? I don't see them there.
Is it working now?
I don't see them. Do you see them?
I see first year EP fellow in 1994, the slide.
Yeah, I think they're shared, Andre.
I don't see them in my screen. Why don't you go ahead and you present it yourself? I only had the 3 slides anyways. I just don't see your slides in my screen.
Well, your first slide is the paper you wrote as one of your first VT paper.
Well, this is just to say that I've been involved in VT for the last 30 years, and it's interesting that this is my very first one, and I think Tim was in. Where were you, Tim, 30 years ago?
I think I was in kindergarten. Yeah.
So, and I think the next 3 slides is just to show that VT remains a very important problem in many different aspects of our daily practice, not only in patients with MI, in patients with non-ischemic cardiomyopathy, but also in those patients who, after getting a primary prevention ICD, they still remain having shocks. And ICDs are clearly a way for you to change the patient's mortality, but it's not a treatment for VT. As we joke in EP, ICDs are the most painful treatment for VT because once you get a shock, you clearly need a different solution for that. And there are, of course, antiarrhythmic drugs. And there is this recent paper from the New England Journal of Medicine, which should be in one of the slides there, showing that when you compare the use of antiarrhythmic drugs, including sotalol and amiodarone, versus catheter ablation of ventricular tachycardia, in many different trials, catheter ablation always performs better than antiarrhythmic drugs. So, and then I think this is what I would like to tell you, because Tim and I, we've been working together for the last 6 years trying to develop different ways for you to offer a good treatment for patients with ventricular tachycardia. You can take over, Tim.
All right, so let's pivot to talk about VT ablation in 2025. So what is it that we do, and what are some of the issues with it, and how are we trying to address this, looking at our own data and our own techniques at Beth Israel? So the traditional gold standard for mapping is to find the circuit itself. These are examples of some of the maps that we create, showing 2 different ventricular tachycardias in a patient with a prior myocardial infarction. These are reentrant arrhythmias, and you can see, if you follow the colors of the rainbow going around, that they are circling around these in these circuits, which is what we target. And so this is the traditional approach, is to find these areas. Find the isthmus is the narrowest, most vulnerable part of the reentrant circuit, where it really pinches down to a waist. We place our catheters there. We turn on radio frequency energy. And then you can see here on this EKG on the bottom that we can terminate the ventricular tachycardia in just a few seconds of radio frequency to eliminate that particular circuit. This is the idealized case, and we wish this was the case that we could do for all patients and at all times, but that's just not the reality. And the reality is, in order to get this sort of information, we have to induce ventricular tachycardia repeatedly. We're putting patients into controlled cardiac arrests, which can occasionally be uncontrolled. So, what are the problems that this can cause? Repeated VT inductions, especially in higher risk cases, these are multimorbid patients or severe cardiomyopathies, can cause cardiogenic shock, especially with these repeated inductions under general anesthesia. It can lead to renal injury, lactic acidosis, sometimes need for bailout mechanical circulatory support, and reduced prognosis and increased short and long-term mortality. And so we've taken a patient who's coming in for one problem and giving them others in these higher risk cases. And if the clinical trials have yet to show an improvement in mortality from ablation, because the ICDs are treating these patients successfully by preventing lethal cardiac arrests, the onus is on us to make sure our procedure is as safe and generalizable as possible so we can avoid this situation. As Andre likes to say, taking off is optional, but landing is mandatory. You have to get the patient through the case safely so that you can offer this as an option to more patients to avoid defibrillator shocks. Well, how do we do this? Well, when Andre came here 6 years ago, when I was just starting my EP fellowship, he quickly became my mentor, and we decided we would embark upon this together as the new guys to see how can we collect our own data and do this in a reproducible way. That's something that's a little bit different, something that can hopefully be picked up more broadly. And to do that, we have to look at your own data. This is another teaching that I've learned from Andre, is that to take care of our own patients, you have to look at your own data. That's the only way you can take the best care of your own patients. And so you need to decide for yourself based on what you learn. And so that's really what we've done. While we've expanded the volume of VT ablations, we are studying our patients and we're studying new ways to do it. So what does that look like in practice? And so this is our paradigm we're going for. We want a shorter, safer VT ablation. And to do that, we're getting as much imaging as we can for planning. We're coming up with substrate modification techniques that don't involve induction of VT, with the goal of same-day discharge, even for higher risk patients, all with the goal of avoiding decompensation. So from a research perspective, how did we approach this? Well, we came up with a handful of research questions that, with the help of numerous trainees and fellows over the past 6 years, we've been chipping away at. So here are the questions. Where should we map? When we get in that procedure, if you know ahead of time where you can map, can you make it a more efficient procedure and reduce the amount of time under general anesthesia? How do we define the arrhythmogenic substrate without inducing VT? How can we ablate VT without needing to even induce throughout the entire procedure, even at the end? And then, if that's possible, can we turn VT ablation into an outpatient procedure, a true outpatient procedure with patients discharged the same day like we do for our lower risk procedures? And then finally, we're not deluding ourselves to think that we have the solutions to all cases. VT ablation is successful in about 70 to 80% of cases. And so the cases where it doesn't work, what should we do next? And so these are the questions we're going to tackle. So let's start before we even get into the EP lab. Can we predict where we're going to need to map with our catheters so we can have a shorter, more targeted procedure? And so with the collaboration of Diana Litmanovich and Reza Nazafat in the CT and MRI imaging groups, we've been working on protocols for patients with defibrillators to image, to get 3D anatomy so we can understand both the structure of the heart as well as the scar here. So here's an example of the reconstructions that we can do with approved software to understand all of the critical structures of the heart, the leads, the nooks and crannies of the ventricle, the nerves, the arteries, so that we know how to navigate the heart and we're not left with any surprises. We can segment scar and show it in three-dimensional views so that we can help navigate using software during the procedure. And this is an example of late gadolinium enhancement from an MRI in a patient with an inferior MI. And we can see that most of the scar is endocardial rather than epicardial to help us guide our procedure, that we're going to do an endocardial approach, so inside the heart rather than having to get a higher risk epicardial access. So we can make that decision before we get there. And then we can get a sense of how we're going to map. This is just an example of a map showing abnormal conduction following the arrows here, following the colors in exactly the area the scar was. And so we can know ahead of time that's where we're going to have to focus our procedure. Same thing with the wall thinning map here, where red is thinner tissue. We studied this rigorously and published it, and we found that those areas of abnormal conduction correlate very highly with areas of wall thinning, especially in our infarct patients. So as a result, we get this imaging routinely to help us know how to approach the patient. What else can we do before we even get into the EP lab? Can we use information from the patient's defibrillators before they get there to help know where to map, even if a 12-lead EKG is not available of that VT to help figure out where it's coming from? And so this is particularly a problem in non-ischemic cardiomyopathy patients because the mapping in tachycardias can be particularly unpredictable here, and there's a higher need to get epicardial access. And so we asked the question, can we use pacing responses from anti-tachycardia pacing? This is something the device is doing automatically, and if it doesn't work, can we learn from the circuit to figure out if it's close to the ICD lead and not need epicardial access, or far from it where we would need epicardial access based on the length of this interval. This was spearheaded by one of our star fellows, Nathan Kong, and we found that yes, with a cutoff of 165 milliseconds, we can actually predict with pretty good sensitivity and specificity whether we need to get that higher risk access. And so now between imaging and this sort of information, we're now being especially selective in the cases that we use that higher risk technique. So the next question is, once we're in the EP lab, can we map VT circuits without even inducing VT? And so this is where we've looked at high definition substrate mapping to see if we can actually predict a focused area to ablate. This is a schematic of a heart, just to show you that VTs only take up a small area of a scar. My little cartoon here, you can see the VT isthmus is just a small portion of the overall gray and red blob here that is the overall size of a scar in, for example, an infarct particular case. And so if you were to do an ablation that you just ablated the entire scar, knowing that the circuit is somewhere in there, you could do a successful ablation, but it would take a very long time, many hours of anesthesia, many hours on the table, with lots of fluids coming from our irrigated catheters that might be bad for the patient with congestive heart failure. And so our goal is, and this, to do a more focused ablation. So how do we do that? Well, our mapping is, at the end of the day, cataloging of abnormal EGMs. These are like EKGs, but of the actual tissue themselves using our catheters. So it's an actual millimeter by millimeter EKG, you can think of it of. And we actually superimpose that into a 3D structure where we can see where those abnormal signals live. The traditional approach was to use abnormal amplitude of the signal, so lower signals more likely to be scar, whereas using activation timing or how long it takes for the signal to occur can give you a different sort of information. And it's only now that the technology is advanced to a place where we can focus on the abnormal conduction itself, which is more similar to the VT, to predict where it's coming from. That is to avoid having to ablate the entire red low voltage scar here. And so what does that look like in practice? Well, we can focus our ablations rather than ablating the entire scar to just cutting off these channels here of conduction block that our mapping techniques can create, that allows us to only have to ablate 15% of the scar in order to make the patient free of VT. And so that's the paradigm we're moving towards. And so as we kind of advance through our paradigm going from inducing the VT and mapping itself, our goal is to find, using our mapping and various techniques that are beyond the scope of this talk, to identify these barriers of the circuits, the boundaries of the circuits in normal rhythm rather than the VT itself, that correlate very closely with the boundaries of the VT, that they can be targeted directly. In our work, we've found that the vast majority of VT isthmuses are less than one ablation size, less than 1 centimeter, which is the size of an ablation, away from these barriers. So if we were to target those alone, with a high percentage of patients, we'll be successful without even inducing VT. These are the results of our VT program themselves in terms of freedom from VT and freedom from death, which matches or exceeds the literature, especially for our infarct cases. Non-infarct cases continue to be a challenge, and we continue to work on techniques for those cases. But we're matching or beating the literature with a shorter time and less of the overall scar ablated. So that's one of the ways that we're moving the needle. What about the patient experience itself and the overall effect of VT ablation on systems of care? So if we do a shorter, safer VT ablation, can these patients even go home the same day, even if they have a low ejection fraction or multiple comorbidities? And the answer is yes. This is work that we did that was spearheaded by Ben Friedman, who is a resident at Beth Israel and is returning as an EP fellow this year. And the question was, are the complication rates higher if we send these patients home? Are they having to come back to the hospital for any reason? After we started doing routine same-day discharge during the COVID era, and we found that indeed, no, the complication rates were not worse in the same-day discharge, especially rehospitalization. They're not bouncing right back. And we follow all of these patients and we keep close in contact with them, but they are indeed able to go home with a high degree of success and a very low rate of bouncing back. And so if we're doing a shorter, safer VT ablation with the goal of sending patients home the same day, if we can, if they are doing well, what are the other things that we can do besides those imaging and our substrate ablation strategies to reduce the risk of hemodynamic decompensation? And one way that this challenges the dogma is, well, do you even need to do any VT induction at all? That is blasphemy in the traditional way of thinking about VT ablation, where you need to target all of the VTs directly by putting the patient into a cardiac arrest on the table. Are our other techniques good enough to get the patient through the procedure without having to do that? And so we looked at nearly 100 consecutive patients with or without VT induction once we switched our strategy to a substrate-only approach in a sizable amount of patients. This was again put together by our star resident and then research fellow Ben Friedman. And what we found is that the rates of complications are a trend towards reduction in the non-induction approach, but with no worsening of VT burden. And so these patients did just as well, if not better, with the non-induction approach as they did with the traditional approach. And so that's why it's now an important tool in our toolbox to avoid decompensation. In terms of outside of Beth Israel, what tools are people using to help predict decompensation during procedures? The most widely used clinical tool is called the Pains D score, which uses several clinical characteristics, these comorbidities that I have listed here, to risk stratify patients ahead of time to low, intermediate, and high. And what we've done is we've used that as a tool rather than just to predict whether patients have decompensation during the procedure itself or in the peri-procedure period, but how should we use that to decide who we use VT induction for? And so this is the framework that we use a lot of the time to decide whether we're going to do a non-induction quick substrate ablation approach versus a more traditional approach. And for first-time VT ablations, if you are a high risk for hemodynamic decompensation and you're an infarct patient, meaning you're more likely to have that good imaging or mapping substrate, those are the patients that we're often doing a no induction approach on. We did one yesterday, in fact, and the patient has done well so far. In the non-infarct patients who are lower risk, where you're less likely to get mappable substrate, those are the cases that we might steer more towards the more traditional approach while we're studying this further. So what happens when VT ablation fails? So we've done these techniques, but the patient has a recurrence despite one or more ablations. What do we do? And so with our VT program, we're trying to have a common approach to how we take care of these patients. It helps us communicate with the doctors outside of our group, especially with the heart failure group, the general cardiology, the critical care groups, cardiac surgery, to have a coherent approach to what we do. This is part of a review that we're writing that's being led by Nathan Kong, another one of our Rockstar fellows, where we look at a paradigm of how we take care of these patients. And so after a first VT ablation, we try to figure out why it failed. That's beyond the scope of this particular talk, but we'll often with a high rate decide to do a repeat VT ablation with a different sort of technique, and I'll show some examples of those kind of higher level or more emerging techniques in a second. And if that doesn't work, we start to think towards adjunctive therapies, and this is where multidisciplinary care really fits in. We are building programs with stereotactic radiation with our radiation oncology groups to target it non-invasively. I'll show an example in a second, as well as doing surgical sympathectomy for autonomic modulation in order to reduce the catecholamine influence of these arrhythmias, which is a common trigger. And then, of course, throughout this whole period, we are working with the advanced heart failure teams to make sure these patients are candidates for advanced therapies if they are, or such as LVAD or heart transplantation, which is of course definitive treatment, all while incorporating the patient's frailty and shared decision making. So how do we implement this complex VT care, both in the lab and outside of the lab? Well, EP is a team sport. This is a picture of me when I was a fellow with one of my colleagues, Dr. Andrew Locke. We were co-fellows together with Dr. Davila, who took this picture from the control room. And so one of the things is we try to work together as much as we can to do these cases. Multiple sets of eyes. We help take care of each other's patients, and we help work together. This is our BIVT center, the EP component of it. Here is our group. Everyone contributes to the VT center, from complex device care to VT ablation to following all of these patients longitudinally. And so we have monthly meetings as a group where we discuss complex care plans for our upcoming VT cases and review prior cases. We often invite colleagues from advanced heart failure or imaging, cardiac surgery, thoracic surgery to weigh in on these cases to help decide in refractory cases should we be thinking of alternative to EP lab type treatments. Not just for direct clinical care, our research footprint is ever expanding, which I'll show in a second. We conduct national physician courses to train in the techniques that we're developing here. And of course, we work closely with our fellows at every step of the game, both in research and in clinical care, as well as expanding our outreach footprint. Feel free to follow our Twitter account, and feel free to, if you are interested, come to the VT Symposium, where several of our faculty are presenting next month, which is the best VT meeting of the year. So in terms of how do we implement this, this is an example of a published case that we did using CyberKnife to treat a refractory VT case that had 3 prior VT ablations that were ultimately unsuccessful. And using the same imaging techniques that I showed you before with 3D reconstructions, where we can create a plan using the imaging where we know from our mapping procedures and imaging where the VT is very likely to be coming from, and then import that into the radiation oncology software to give a targeted non-invasive treatment. And this patient has overall done very well. For sympathectomy, this is an autonomic modulation. This is removing the sympathetic chain inputs into the heart, literally with surgery in a minimally invasive approach. This program is led by Dr. Gangadharan from the thoracic surgery program. And we do several of these cases a year, an increasing amount for our refractory cases, so it can be another good adjunct therapy. For our heart failure referral pathway, we've developed a more systemized way of deciding which patients are the ones that should have early involvement or consistent involvement from the advanced heart failure crew, who can not just decide whether these patients are candidates for advanced therapies or bail out mechanical circulatory support, but help them be optimized throughout their entire journey before they get to the EP lab, and not meeting them when it's too late if they have already become a refractory case. And so that we incorporate this into our practice pattern, and we've developed this over the past year or so. And then physician courses. As we try to spread the gospel about our different way of doing things for VT ablation, we've got significant interest from attending physicians and fellows nationwide to come and learn these techniques ourselves, whether it's how to do substrate ablation or how to do epicardial access. We teach in the animal lab this higher risk technique and how to do it in the safest possible way. I mean, big credit to Dr. Locke, who organizes all of these courses for our EP program here with great feedback from the learners so far. So where are we going in the future? Especially for our most difficult cases, how can we make the procedures even shorter or even more effective? And so for the last few minutes, I'm going to talk about where we're going in terms of technologies. with our VT Center, as well as our expanding research footprint. We have the benefit of having access to early feasibility and pivotal trials for emerging technologies to deliver better and deeper lesions. That's one of the main reasons that a VT ablation might fail, is if the current radio frequency techniques just don't get deep enough into the tissue where the circuit is actually living. There's been great advances in both pulsed field ablation. This is the trial we're recruiting in now using this catheter, which rather than using heat energy, hot or cold, uses high frequency, high voltage pulses to actually cause pores to form in the tissue that's selective to heart tissue. So that's one trial that we're doing, that we're recruiting in. And then ultra low cryo. This is negative 190 degrees cryo energy to deliver up to 1.5 centimeter deep lesions. And so these are trials that we've successfully recruited for at Beth Israel in the past year. And I'm happy to talk offline more about whether patients might qualify for these. This is an example of the catheter in action at Beth Israel. This is the catheter sitting right below a mitral annuloplasty, which is a particularly hard area to reach with radio frequency with a very successful ablation in this particular case. Here's an example of that pulsed field catheter in action, and this is an example of a single pulse terminating this ventricular tachycardia, which is a completely remarkable feat, that a single pulse from energy that lasts a fraction of a second could terminate a ventricular tachycardia. So it's a very exciting time for us, and it's going to continue to lower the threshold to take patients to the lab if we think we can do it more effectively and safely. In terms of devices, we're recruiting for multiple clinical trials, looking at new ways of deciding whether to do conduction system pacing versus resynchronization with left bundle leads versus traditional resynchronization. This is being led by Dr. Locke. Dr. Zimmerbaum is leading a trial where defibrillator leads are now being placed into the conduction system itself to help reduce pacing cardiomyopathy, and that's another IDE early feasibility trial that we're just starting recruitment for again. So in the final minutes here, we'll talk about our research footprint. So we have our research clinical footprint. I've showed you several examples of already, but we've got many other projects, including looking at frailty led by Evie Goodyear. Dr. Wax has a very robust vector cardiography program looking at EKG information to predict risk of VT inducibility and sudden death. Doctors Farrow and Brodeur and many other colleagues are looking at outcomes data via the Smith Center. We've got our industry-funded multi-center trials where we have a seat at the table of some of the most exciting technologies, as well as a preclinical lab where we're looking at newer technologies and that hope to be safer and faster as well. So really a global view of investigation that we're building here. In terms of our VT volume, it continues to grow year by year as we get the word out and use appropriate patient selection. It continues to grow at a robust pace, and we hope it to continue to grow in the future, all with the goal of working as a team at Beth Israel to develop a shorter, safer VT ablation. I'd like to acknowledge all of my mentors throughout my training and early faculty years here, as well as all of the many fellows and residents and research students and fellows who've worked with us to make this happen. And so I'd like to thank everybody for joining us. And for the visiting fellow applicants, please enjoy your day, and happy to chat offline anytime. Thank you so much.
Terrific. Thank you both for that presentation. We actually have 2 minutes here before 8:45. If anyone's got any questions, we could probably take one question now. And if not, I might just ask one question if that's okay. I mean, it looks like you guys have done, what, 600-700 VT ablations in the past 5-6 years. And so that's probably more than a lot of other centers in the US. Have you learned anything about kind of patient, what predicts VT success here, efficacy, in terms of patient-related factors or substrate-related factors?
Good question. The best predictor that we have for a patient who does well with from an efficacy standpoint is having an infarct cardiomyopathy versus a non-infarct cardiomyopathy. The unsolved problem in VT ablation is what to do in non-infarct patients, which are a very diverse group of patients ranging from sarcoid to genetic cardiomyopathies, ARVC, HCM. They often have focuses of tissue that are less likely to be mappable because they're deep inside the tissue. And for that reason, if we can't find it, we can't fix it. And so that's really the unsolved problem. And so our rate of success continues to be very high in infarcts, and it continues to be a great option for drug refractory VT and the non-infarcts. But that is an area where we hope that the newer energy technologies that can get deeper into the tissue will be more successful. So I would say to give a single answer, that is the highest predictor of success is an infarct patient.
Okay, it looks like we've reached time. So if anyone has any other questions, please feel free to message Tim or Andre directly. Thank you both again for that terrific presentation.